can be in the de novo metastatic, like the synchronous, or it can be metachronous metastasis. Oligometastatic is a state of limited number of metastases combined to a single or limited number of organs, and it is in head and neck cancer. It is most frequently manifested as viral-related pharyngeal carcinomas. Example like Epstein-Barr virus positive nasopharyngeal carcinoma or HPV positive oropharyngeal carcinomas when compared to non-viral related head and neck cancers, which mostly present with as a distant metastasis, often follows or may coincide with the locoregional failure. Again, oligometastatic setting is a kinetic manifestation, and it may progress into polymetastatic disease if it is not treated properly, and conservatively, and conversely, if polymetastatic disease is treated, it may change to oligometastatic disease. This is especially important in the era of immunotherapy. By definition, if we look in multiple studies, even metastatic site up to 10 have been taken in some studies as oligometastatic disease, but for a consensus, we can say that 5 or less number of metastatic site in with a limited disease burden can be considered as a oligometastatic disease. And again, this can, as already told, it can be synchronous or metachronous. Metachronous is sometimes referred to as oligo recurrence. Also, there is a term called oligoprogressive, and it is loosely defined as a progression to a limited number of sites after the systemic therapy that has resulted in relatively disease stability, including partial or complete response. It has been hypothesized that oligoprogression results from tumor heterogeneity, where progression is observed in drug resistance subclones in a small number of sites. So this picture depicts the spectrum of disease from a loco-regional. It can also have synchronous metastasis called synchronous oligometastatic, or can have oligorecurrence or metachronous disease. If there is more further disease progression, it can be oligoprogression, and if there is a wide disease display, it can be a widespread metastatic disease. Again, important to know that the most common site of distant metastasis in squamous cell head and neck cancer is lung cancer, which is present in around 70 to 85% of the cases. The second most common is bone, which can be present in up to 20% of the cases. Liver, brain, mediastinum, skin and bone marrow are other less common sites of metastasis. Now, what we have for the treatment of metastatic, we know that the treatment options available to us are still unsatisfactory. Platinum-based chemotherapy along with cetuximab achieve a median OS of around 10.1 months as per the extreme trial. Now we have TP extreme trial, which includes docetaxel with platinum and cetuximab, and it has also shown over survival in the tune of 10 to 14 months. Even with the incorporation of immunotherapies like nivolumab, pembrolizumab, and with the incorporation of TKIs, and as data presented by in the previous lecture talk, the median OS is still in the range of 14 to 17 months only. So what are the treatment options for the loco-regional treatment in the oligometastatic site? The first is the surgical management, that is metastatectomy. And again, in this we have the data available to us are the retrospective studies, and those in the pre-immunotherapy era. We can see we have in this meta-analysis we can see the 3 studies. 2 of them are from 2009 2008, and the third one is in the 2019. And in all the 3 studies, the metastatic 100% of the patient had metastatic size location in the lung, and we can see that after median follow-up of around 58 to 120 months in the different studies, the OS at the end of 5 months was 54% and 26.5%. In another meta-analysis, we can see again these studies are done in the pre-immunotherapy era, and we can see that after the local treatment in the form of surgery, the median survival could be achieved in the tune of around up to 77 months based on the patient selection. Also, 3-year survival and 5-year survival has been reported in the tune of 67% and 50% in the oligometastatic setting. Based on these meta-analysis, certain variables have been withdrawn which improve the prognosis following pulmonary metastasis. These include young patients, female gender, non-oral squamous cell carcinoma, no cervical lymph node metastasis at the diagnosis of primary treatment, long DFI, and complete resection of the pulmonary metastasis. Along with this, in certain studies, it has been shown that they have considered less than 3 sites, metastatic sites, and the tumor less than 1.3 centimeter to be a favorable factor in this setting. The other option available is SBRT, and again we have usually we have our data available to us in the form of retrospective analysis only. A few prospective phase 2 data are available, which one of them is about the SABR Comet trial, in which 99 patients were treated by the SBRT, out of which around 10% were of head and neck cancers. Patients were given treatment of choice or radiation, and it showed a significant improvement in the 5-year overall survival from up to 42% compared to 17% in the comparator arm. In one of the retrospective meta-analysis, again it comprises of retrospective studies. It has been shown that OS can be achieved in the tone of around 40% in up to the 5-year OS can be in the tone of 40%. In one of the study published in 2020, that is by Pasalic et al. Again, 100% of the patient had metastatic site in the lung. The 1-year OS was around 74.8 months, and 2-year OS was 61.8 months. Now, talking about the combination of these local therapies with the emerging systemic therapies, the concept is based on the theory that stimulation of immune responses enhances the systemic response, and it has been shown that the local radiation therapy increases the anti-cancer immunity by triggering the immunogenic cell death, which can promote systemic inflammation and immune-mediated activation of antigen-presenting dendritic cells and cytotoxic T cells. Many preclinical and early clinical data has shown to increase the effect of the radiation in the immunotherapy, in the immunity of the patient. Again, the radiation is again a double-edged sword. It can increase the immunotherapy, but has shown in many studies to induce the immunosuppressive response also. Most of the trials assess the combination of radiotherapy with immunotherapy and as a single site radiation, although we have which assess the abscopal effect. Also, we have studies in which multiple targets were being radiated. So, talking about this single site radiation, there is a pooled analysis for 2 randomized trials. Although it is from the non-small cell lung cancer, but it can give us an idea about the concept. So in this, Pembrolizumab with radiation was compared with the RT alone to show the abscopal effect, and with the Pembrolizumab and to show the abscopal effect, and it showed response of around 42% compared to 20% with the Pembrolizumab alone. In another phase 2 trial, it also demonstrated abscopal effect with the combination. It failed to demonstrate. It failed to show the abscopal effect with the combination. In a recent trial with the Memorial Sloan Kettering group, again they radiated the out of the polymetastatic site. They radiated a single site, and again it failed to show the abscopal effect with the overall response rate of around 34.5% with the nivolumab compared to 29% with the combination. Talking about the multiple site irradiation, again there are several ongoing studies. It is based on the hypothesis that multiple site irradiation enhances the treatment synergy through reduction in the disease burden. Also, it increased radiation-induced immune response can be seen in this setting. So, with this concept, many ongoing studies are there. Out of which we can see that 3 are phase 3 studies, 2 are SBR Comet 3 and SABR Comet 2. In SABR Comet 3, the disease type is comprises of any oligometastatic cancer with the metastasis in up to 3 in number, while in Comet 10, the metastatic site can be from 4 to 10. So the final primary outcome point for this both trial is overall survival. If we talk about head and neck cancer, we have importance trial, MDACC group trial and OMET trial. These are all phase 2 trial, and they are comparing immunotherapy along with the radiotherapy or immunotherapy alone. And again, in these trials are still recruiting the patient. Another phase 3 trial is the oligo-rare trial, and it involves a rare oligometastatic site with the primary endpoint of overall survival. So to conclude, we still lack prospective data to come to a new conclusion about the role of local therapy in the oligometastatic sites. Randomized control trials are needed for better elucidation and the true risk and benefit of local treatment for oligometastatic head and neck cancer. Although NCCN and ESMO recognizes local ablative therapy as an option for patients with oligometastatic disease, current evidence supporting the role of local ablative therapy is based on only retrospective data. Thank you.
Any questions?
Thank you.
Can I ask a question?
Yes.
Can I ask a question? So in the era of immunotherapy, as we are combining local treatment, can you highlight what is the ideal time to give radiation? Like, because as you told that it is a biojet spot. So with combination of immunotherapy and radiation, sometimes the response rates are high, and at the same time the side effects also increase. So do you suggest some like 2 to 5 half? Like, what is the ideal time to combine, or
Actually,
would you stop?
we are having the retrospective data only, and in those trial it was shown that the radiotherapy was given initially and then immunotherapy was started. So in that we have both type of results to favor to in favor and in against giving the radiotherapy, as it has also shown that it diminishes the effect of immunotherapy. So based on these data, we cannot come to any conclusions. Maybe the further studies which I have highlighted, they will give us a better picture of what is the timing of this radiotherapy.
Thank you.
One question.
Fine.
Is there any biomarker which can predict the oligomers?
Sir, I have done a very thorough research search for this presentation because it was not available anywhere, and I have not come across any of in this study about this for the marker which can predict. So I'm not aware of that.
Thank you.